it's just a little bit on my bio. I probably in particular just for those that are interested, I started working with Invisalign a little over 16 years ago when it was first available, and have had a chance to be on their faculty and presented certification lectures to over 20,000 GPs at this point, probably about 22, I guess. But I think the most important thing is what I'm bringing up on the screen right now, and that's that I practice full-time in Washington, D.C., and I teach on Fridays generally and do occasional webinars in the evening. Just a little bit also about myself. I'm not employed by any dental company. I'm on the faculty of a number of different institutes and some of the dental companies as well on their KOL boards. But I don't own any stock, securities, or interest in any of the dental companies, and no one in my family does as well. I feel that's important to share with you because I want you to know I don't really have an axe to grind. I'm happy to tell you what works and what doesn't work. Nothing works all the time, and some things will work a lot of the time. So what we want to do is take the things that work best. These are the companies that I'm consulting for presently, or have recently consulted for. We don't generally accept any free product. We'll test stuff and get it back when we're done. And it just allows me to have a hands-off approach with being able to share the best information with you. With that said, our focus tonight is going to be on accelerated orthodontics. Anything I refer to can be found in a most recent article that I did in Dentistry Today about a year and a half ago. It's got about, I think, 57 references in it, which can really kind of bring you up to speed on anything you have questions about with general ortho or accelerated ortho. And I'll refer to it today, but if you want to, you can go ahead and get a copy of that online. It's pretty easy to get a copy of, and you can use that as a reference if you need to as well. So I want to talk about ortho training a little bit. You know, I can pretty much bet that every person that's on the webinar right now did not do a full comprehensive orthodontic case in dental school. And the reason for that was real simple. We just didn't have the time. As a matter of fact, most ortho residents don't get a chance to complete a comprehensive case while they're in their training. And that left us with just some interesting options. You know, we could go ahead and go to an ortho residency, become an orthodontist. We could stay at GP and do nothing and use the referral slip, which most of us did for years. And then finally we could take a lot of CE, which is what I started doing. We had to have a required segment of ortho training for the mastership in the AGD, and that was where I first was exposed to it, and was a little perplexed. And part of the reason that I was a little perplexed was the Old Boy Network had kind of socked it to me, as they did most dental students, and it was like a little kind of secret club, and we didn't learn much ortho when we were in school, and it was a shame because a lot of the European schools teach it as part of their curriculum. With that said, it set us off to find ways that we could do minor tooth movement, and that was really what happened in 1999. There was a complete digital disruption, as I like to say, with clear aligner therapy coming to the fore, generally with Invisalign kind of leading the way, and they still lead the way, although interestingly a lot of their patents will be expiring in the next couple of years. But that changed the landscape for us because it gave us the ability to do things that we weren't able to do in the past. We could now perform simple cases and end up with really, really great results, and we could actually look at them predictably via ClinCheck and some of the other nice software things that came out to help us accomplish our goals. It changed also because initially, like most of dentistry, orthodontics was really an apprentice modelship. We'd look and learn from other people on techniques and kind of master it from there. But also around the 90s, evidence-based science kind of came into play with all of healthcare, and we base pretty much everything on evidence now when we look at procedures and techniques related to it. Well, that really was something that Align was able to jump on because they had so much data and created a huge database from their cases. So with that, something else changed, and that was, in essence, that cosmetic dentistry changed, where we used to be able to grind down a lot of enamel and glue stuff to teeth, which we could easily do after the 4th generation bonding agents. We no longer could really say that that was a good option if moving the teeth was a better one. I share my case. Some of you may have seen it before. This was my seminal case for me, getting shaken up with the whole idea of cosmetics. And we were doing a lot of veneers and bonding and all sorts of stuff back in the 90s with great results. And this, you can see, this is even taken with a slide film. It was long before digital film was even available. And this before picture and the after picture for the veneers, the woman who we did this on was just over the moon with the results. She was thrilled. I've sent my pictures off the Ritz camera, and I got my slides back a couple weeks later, and I was looking at them and patting myself on the back when all of a sudden I noticed that I had reproduced her midline. You can see her lipstick changed a little bit, but more importantly, the midline was exactly where it was. She didn't really care, but it really bothered me because I couldn't get over it. Around that time, again, late 90s, Invisalign came along, and I found a case that was similar. Another woman who'd wanted veneers, and she had number 9 almost in an identical kind of position, a kind of cocked position. And I said, you know, let me try the clear aligner therapy to straighten the teeth. I'd like to try that instead of cutting them down and see what we can get. If it doesn't work, we can always do the veneers. And we ended up with a really, really nice result. Again, that number 9 just reminded me of the number 9 on the previous case I talked about because it was a little bit on an angle. There would have been a lot more tooth reduction with that diastema. Well, by moving the teeth, we not only were able to give her a nice smile, we were able to do it super conservatively, and we were able to put that tooth in a better position. That was probably the seminal part of changing my thinking with veneers and crowns and a lot of my cosmetic dentistry, because as I mentioned, that number 9 mimicked the number 9 of that previous case, but what I didn't share with you is that underneath that veneer is an angled tooth. And I can tell you that the one tooth that will fail first in this veneer case will be that one because it doesn't have proper support. So I looked at that and again changed my thinking and started to embrace Invisalign. This is just another kind of typical case. Kendra had come in with actually not even backing up here. She didn't even come in initially for anything related to aesthetics. She was wedging food in between her teeth and was in a lot of pain from it, and we looked at her and kind of talked about the different things we could do, walked her through just clear aligner therapy, moving the teeth into a better position. As you do that, you can see those class 5 abfractions are really starting to show. Number of other things like the wear on some of the teeth, in particular, look at the bicuspids there and that one lateral, and they wore down a lot, and then we straightened them out, and those areas of wear became more obvious. But I had something that the orthodontist didn't have, and that was an extra trick in my bag to be able to restore Kendra to a nice smile, to give her a nice smile that both was functional and aesthetic. So after moving the teeth into the right position, we went ahead and just did a little bit of bonding, and you can see this is immediately after the bonding, and we got things looking pretty good. I'm a little disappointed in my reflective zones on those front teeth, but I got the nice. That bicuspid even, we built up cusps a little bit on the sides there to give her a little bit of cuspal just appearance. She's got great guidance off her canines, and that's how she finished up. She was thrilled with the result, sent in a number of patients, and things really changed. But obviously the biggest challenge with her was that snaggled tooth, the canine that was out of position, and bringing it in was the biggest challenge for us. So with the idea that we knew we could use clear aligner therapy to accomplish some really great cases, we started to take on new challenges, generally taking more challenging cases, sagittal changes, difficult rotations, and extensive crowding cases. But one of the things that patients really were looking for was shorter treatment times. And the idea behind having shorter treatment times was that they didn't mind necessarily the going ahead and getting through ortho and having something that was cosmetic. They just wanted it to be quicker. So different methods that were available and still are listed right here. I'm going to walk through these because I want you to understand kind of what happens and how. So we'll talk a little bit about them. But before we do that, I want to talk about just basic tooth movement for you so you understand kind of how things work. In essence, you have a compression side where the bone resorbs and it's done by osteoclasts, and you have a tension side where you actually grow bone via osteoblasts. The monocytes inside the blood vessels will go ahead and differentiate into preosteoclasts or preosteoblasts and lay down or take up bone, and that resorption process turns into reversion and then the formation of bone and finally mineralization. If we look at the bone modeling process with just a bracket, you can see we put some pressure on that bracket with our wire, and we go ahead and drag the tooth through the bone. So before jumping a little bit too far ahead of myself, I'm going to go back a little bit in history to the 50s and talk about Dr. Burstone's classic 3 phases of force. With ortho, there really can be broken down into 3 different types of movement. The initial force, which we call the strain phase, is a real short period of time when we put all the pressure on the tooth to move it through the bone. It then goes through what's called a hyalinization or lag phase, which is about a 2 to 3 week period where the force is against the bone, but there really isn't any tooth movement because the tooth is pushed up against it. And then finally what they call the post-lag phase, where that hyalinization layer breaks down and it causes rapid tooth movement via the osteoclast resorbing. So if we look at that model now, we go ahead and put our pressure on that tooth, and we'll go ahead and have the osteoclasts do their job, taking away some bone, and then the tooth is able to move along with it. And that's frontal resorption when we see that occur. Now, when we talk about resorption, there's another thing that dentists are very aware of, and that's called EARR, or external apical root resorption. Generally, it's I think pretty much a proven fact that it's caused by excess velocity. There's other minor causes, but when we look at tooth movement, it's too much force put on the tooth, and as it pushes the tooth, trying to push it through the bone too fast, the tooth ends up giving up and actually shrinking, resorbing. We don't see that at all with any of the clear aligner therapies, and there's a real simple reason for it. You can't put enough force on with clear aligner therapy before the plastic just deforms. If you try and put someone in an aligner and they try and change it every single day, you're not going to be able to have the tooth move fast enough. What happens is the plastic just doesn't fit anymore. So I like to use what I call my fence post analogy. The fence post analogy is real simple. If you imagine that you have a fence post and it's sitting in concrete and you try and move that fence post, it's going to be very difficult. And that's in essence what we try to do with our traditional brackets, was try and drag that tooth through concrete. Well, what if we change that concrete to quicksand? Now you could apply a nice constant steady velocity to the tooth, move it through the quicksand to the right position, and then let the quicksand turn back into concrete. In essence, that's what we're doing with any of the models of advanced accelerated ortho. So going back to our resorption model, and now talking about how you get that EARR to occur, we'd go ahead and we'd put force on our bracket, and we'd put a ton of force on it, a lot of heavy force, and what it's going to cause is some undermining resorption. And the reason is that the force is not really like that. The force is more like that. And as it pushes, the apex of the tooth gets pushed up against the tooth and against the bone in the other direction, and the resorption then occurs down at that apex. There's breakdown that you'll see occur, and the root will end up shrinking. We've seen lots of models of that, and we've seen lots of x-rays of it in our practice. In this example right here, those front teeth were moved and through some rapid ortho, and you can see what happens. It also, as you know, can occur with other things. Traumatic injury, etc., can cause resorption. But when we're talking about ortho, we're going to look at the velocity as being the primary cause. So how do we make that bone softer? What do we do to turn that concrete into quicksand? Well, the entire idea behind this movement of accelerated ortho is something called the regional acceleratory phenomenon, or RAP. And again, it's making that concrete into quicksand so that we can move the tooth faster. The mechanisms for the different types of ortho out there for accelerated ortho are different, and we're going to just walk through those real quickly. Probably one of the first ones that people were heard about or familiar with is something called Excelleration. It's cyclic forces of vibration. It was approved about 6-7 years ago, and the patient basically bites on a little rubber thing that looks like a mouth guard, and it has a certain kilohertz of vibration, and that vibration causes the teeth to move. This is what the Excelleration product looks like. That's what it looks like in the mouth for the patient. And in essence, those vibrations really help to speed up what's called what we consider to be the lag phase, that second phase, by allowing what they consider greater tooth movement. There's some interesting science out there that's evidence-based, and there's I think a lot of speculative science that we're still looking at. It's an interesting phenomenon, though. Pharmaceutically enhanced tooth movement, there's a ton of things that have been tried in the market. There's none that are presently commercially available, but they've tried everything from injections with corticosteroids and calcitrol and different vitamin formulas to help accomplish the goal. Lightwave accelerated bone regeneration is another very interesting one. A company out of Vancouver, Canada, Biolux, came up with a product that uses a near-infrared light-emitting diode, and this is actually taken originally from orthopedics to help with bone healing, and that's where they first started using it for implant integration. This is what their product looked like for implant integration. The idea is very interesting. It allows the electromagnetic light waves to help to initiate more cytochrome C oxidase, which will make more ATP, which in essence will help in mitochondria, which helps to in essence add energy. This is what the Biolux product looks like. It received its FDA approval about 6 months ago, about 8 months ago, I guess. And we've looked at a number of these, and it's an interesting phenomenon right now. Next is the laser-assisted method, which they call Leli. Leli is very interesting. There's no products available. That's a picture of my lovely wife, Deneen, in the chair. And we're looking at using it to help rotate a lateral. Again, no products are available. There's been a lot of research, though, and it's I think got some promise to it in the future. But probably the method that most people are familiar with is the decortication techniques, of which there's really 3. The method is pretty much the same for all of them. What you're going to do is create an insult in the bone. You're going to create an iatrogenic area of inflammation that's going to cause what they call a transient osteopenia, and that transient osteopenia causes a weakening of the bone, probably the most proven way of turning that concrete into quicksand. It was originally developed by 2 brothers, Tom and Bill Wilco, up in Erie, Pennsylvania. They introduced the idea in 1988. They've got registered trademarks on the names of it, but the idea is that it creates the inflammation. These pictures taken from their website can show that it's a pretty drastic technique. This is not, as some people originally thought, sectioning bone and moving chunks of bone. It's just creating big areas of inflammation to allow the teeth to move rapidly. Again, there's a number of different names for these procedures, but Wilcodontics and Accelerated Osteogenic Orthodontics are both registered trademarks of the Wilco brothers. With that, a number of the different specialties have come up with their own unregistered names, and probably oral surgically assisted accelerated orthodontics is probably the most common one. This is one that I did with my oral surgeon a couple of years ago. Patients getting ready for a couple of implants in the lateral position, where there's some cantilevered pontics off the 2 centrals right now from an old bridge. We've got them in some acrylic temps, and we're going to go ahead and actually build up those areas for the implants. But we're also going to tilt the roots, because there's a distal root tilt on the centrals and a mesial root inclination on the cuspids in this case. We want to straighten them out so we can make space for the implants to be placed. That's the procedure. While it's being done here, we're packing bone in afterwards, and there he is all closed up. We just finished up Justin, and I'll have his full case ready at my next lecture for you, so we can kind of walk you through that. Piezo-excision is a kind of more version of the original Wilco technique. It's definitely less invasive, and you can, I think, perform it without causing as much soft tissue insult. The idea is, instead of flapping back all the tissue, you just make small incisions, and then you take your piezo device and you put it in there. It's very similar to a striker saw or even a cavitron. It's going to vibrate at a certain wavelength and cause these little incisions to occur, so that then after you've made the incisions, that inflammatory process spreads out from around them and allows for that, again, concrete to turn to quicksand and the teeth to move. Finally, Propel came along. So why did I run you through all this history on accelerated ortho? The reason's real simple, is that this by far is probably the most promising of any of the techniques that are going to involve decortication. As a matter of fact, we don't even use the term decortication. We like to call it micro-osteoperforation or micro-perforation. using the Propel device. The nicest thing about it is I'm able to change aligners weekly with consistency instead of every 2 weeks with the standard Invisalign technique. The whole procedure is exactly the same as the other corticotomy methods, and that's where we'll create that inflammation. That inflammation causes a cytokine cascade to occur. The cytokine cascade causes the bone to remodel faster, and with that there's a decreased density of the bone. The decreased density allows, again, the teeth to move faster. The original device developed by Propel looks like this. It was called the Excelleration, and it was a handheld plastic device. It had a couple of really cool things, in particular a little LED light that helped to tell us when we hit the right depth. You could set this to 3, 5, or 7 millimeters and go ahead and place it from there. It was a lot of plastic waste, and just kind of being ecologically conscious, I was not really happy with that aspect of it. You use it once and throw out all that stuff. So they came up with a second one, which is an Accelerator RT, RT standing for a removable tip. And this is where you have a nice kind of heavy handle that you can hold in your hand. It's not too heavy, but it fits firmly in your palm. And you pop in those two little devices you see on the right side there. Those are just two different types of the tips that they have, the options for tips. And then when you're done, you just throw out that little plastic tip. So looking at the Propel technique, in essence, what you're going to do is look at the area where you want to place your perforations. Have them do a chlorhexidine rinse. We'll have them do it a couple times for a minute, just to help, I think, push down the load of bacteria. Then we'll go ahead and anesthetize them. I'm going to talk about the different ways of anesthetizing. And then we'll go ahead and perform the Propel technique, and the patient's all set to go. Here we are using the original one, and you can see just the light. As the light comes on, tells you that you've hit the right depth. You just twist it in like a screw clockwise, and then when you've hit the right depth, you just rotate it back out. The Accelerator RT, exactly the same, but it doesn't have the little LED light, which is, I think, a nice little indicator of when you hit the right depth. It does have the sleeve on it, that little clear plastic sleeve that's marked at increments of 3, 5, and 7 millimeters. Again, once you've hit the right depth, you just go ahead and rotate it back the other way. Show you a little video real quick of how the technique itself works.
Now with the device, we have 3 different measurements at which micro-perforation can be made. They can be made at 3, 5, and 7 millimeters. In the anterior segment, we usually use 3 to 5 millimeters, and using it in the posterior area, we usually use 5 to 7. I'm going to use 5 millimeters on Maria. What we're going to do is place this on the 5 millimeter mark. We're going to place it right where we want to go between the roots, clockwise. Wait until the light comes on, and then you just reverse the application.
That gives you an idea of how you use it in action. We'll look at some slides of that in just a bit. There's some nice things about the markers, the indicators on there, and that, just to give you an idea, she mentioned that we'll use 3 to 5 in the anterior and 5 to 7 in the posterior. Just think as the cortical plate gets thicker, that's where you're going to want to use a little bit more depth to be able to penetrate the cortical plate, which is all you really need to do when you're using the Propel device. You penetrate the cortical plate, and you're going to create a small sphere of inflammation that will cause that cytokine cascade to occur. That sphere is generally about 5 millimeters, and that's kind of what I look at when I'm using my my Propel device. This is the latest Propel device to come out, and it's in essence, it's like a TAD placement device. You go ahead and use this. It doesn't have a cord to it, and it doesn't have. It's not air driven. It's just you recharge it, and go ahead and you can place it where you need to, and use this, and it makes it a super easy procedure for us to go ahead and do. This is what it looks like. There's the top part, and those are the tips on the left-hand side. It's pretty intuitive. It makes things a lot easier to use, I think, as far as the procedure is concerned. And I think the patients see a lot more comfort when we use that. I'm going to just kind of look at, if we look at the 3 different Propel instruments, I can talk about kind of the different pluses and minuses of them. So with the new one, with the RT, super easy to use. I like to say that you don't have to have Popeye forearms to do this. That's one of the things when we're using the handheld devices, that the old manual devices, you really have to, sometimes be firm. Like in essence, we rest my other arm against the patient's head, and so I can just create force without having them move away. And this, you don't have to do that. It's intuitive. It looks like there's a lot of buttons on it, but it's pretty easy to figure out after just a one-time through practice session. I get really nice tactile sensation with it, which I think is a big plus. It's super weight, and I don't develop that fatigue, as I'd mentioned. Probably one of the nicest things I see is that it's very eco-friendly. We just throw out that teeny little tip. It's like a burr as far as the disposable part is concerned. If we look at the original device, this by far probably has the best tactile sensation for me. I can feel exactly where I'm at. I love the little LED light that's in this generation. The first generation one tells me the depth, and it's ideal for small areas or quick cases. Pretty much the same thing with the removable tip one. The second one, the second generation came out, but it didn't have the LED light. A lot more eco-friendly. I call it eco-kinda. The thing I like about this is it's got good heft. I can feel it in my hand and use it easily. So we have all the different ones available for different procedures. The ones on the right side are great if I've just got a small area. I can go in there and just get around a canine or a rotated tooth, or trying to fix a small crossbite. I found that this is a very, very helpful thing to have the ones on the right side. Bigger case, we'll go ahead and do the one on the left side, and it's very similar to as if you were doing IPR. If you got a couple little spots of IPR you're doing with your cases for ortho, you may just use some little hand strips. If you got a bigger case, you may use, either a disc followed by hand strips, or a disc and a lot of the little ortho reciprocating devices that you can use to help smooth the teeth. So pretty much follow that model. The manual for small cases, and for bigger ones, we'll go ahead with the machine to help accomplish it. Now, how many perforations do I place? First off, we'll talk a little bit just about the technique that we do it. Really, you can do either kind of a triangle or a straight line, linear. And I'll do it to accomplish that 5mm sphere. That's what I'm looking at. So for lower laterals and centrals, I'll probably just place 2, as you see on the left picture on the bottom left, those 2 dots. That's typically what I'm doing. If I've got a really rotated tooth or one that's lingual and I need to bring out, I may place 3. And I may place just a single one if I'm just trying to free up the movement a little bit, create that little bit of inflammation so we can get the teeth moving. How do you, where do you place it? Well, you can place those guys anywhere you want, so long as you don't put it in the nerve. And obviously that goes with anything in dentistry. So we visualize where the nerve is. We'll be aware of an anterior loop where it comes out of the mental foramen and may swing back on occasions. I'll share with you kind of some things about that when we get to best practices a little bit later on, but it's easy, very easy to avoid hitting a nerve, and it's easy to avoid hitting a root too. This is the Propel sheet that we use. I'll do my treatment planning and draw out the areas on that the tooth map in the middle part there where I want to place them, so my assistant has it ready, and then that way if I come back and do a follow-up, we know exactly where we want to place the perforations again. This is a product checklist that Propel came out with. They've got a new one that they just came out with that's even easier and clearer, but the idea is just to have everything ready to be able to do the procedure itself. One of the things that we use with the procedure, talking about the anesthetic aspects of it, is just a topical anesthetic for a majority of our cases. Now, regular topical anesthetic is okay, but it really doesn't penetrate as deep as we'd like to. So they came up with these different things called profound gels. It's a compounded type of anesthetic. It's real thick. It's very similar to EMLA for anyone who's used EMLA in the past. They have a shelf life, a limited shelf life. We usually use them up in 3 months and it works fine in 3 months. I think if you have it sitting around for a year, it may not be as effective. But we typically use the one on the right, the heavy-duty version, which has a 12.5% tetracaine in it to really help give it a kick. These are the different pharmacies. You can get this information from Propel also. We use Woodlands, the one up on the top, to have them go ahead and compound our gel. All you have to do is call them up and tell them you want the strong, profound gel, and they'll mix them up for you and send it to you in a little syringe, a little 10 cc syringe. So how do we put this on? Well, first we'll have them do the swish with the chlorhexidine, or if it's just a small area, we may just wipe it down with chlorhexidine with gauze. Then we dry off the tissue, and we'll go ahead and put that layer of the topical on, and we put it on gauze and just lay it on the tissue, and we let it sit there and do its thing for generally 4 to 10 minutes. And then we'll go ahead and test with the perio probe. We literally will do sounding, and if the patient has any sensation, we'll reapply. If that doesn't work, we go ahead and just give them a little infiltration. That's what one of the tubes looks like. There's some gauze strips out that we'll just squirt the stuff onto, and then we go ahead and just lay it in place. And that's the strong one there, the strong material, and it looks like that green. We just lay those little things right up on the tissue, and then we go ahead and let it sit and do our thing afterwards. If we're going to give local anesthetic, we don't need to do a block. We're just getting the bone and the soft tissue in particular right in the area we're going. So even if I'm doing it in the back, I just give them a little infiltration. Probably most importantly is the second bullet point here is that the cortical bone doesn't have innervation. So I'm not worried about sensation in the bone. It's more the soft tissue sensation that we're considering. Also, people often ask, do we place it in the unattached gingival, the mucosal area? And the answer is yes. I'm going to go with where the roots are, and oftentimes I'll go down into that mucosal tissue to go ahead and place it. The one big thing we want to worry about or pay attention to is that we don't want to hit a PDL. I've managed to do it twice. Both times I knew right away. The patient let me know. The first time I didn't pay enough attention, and I kind of kept going. She said, you know, that's really sore, Brian. So we stopped and backed up the second time, and that tooth was sore for about 2 or 3 days. I'll cover a little bit more about the PDL later on in the lecture. If we do have to use local infiltration, we typically use just a septicane, 1 to 100. It's fine. You can use 1 to 2 or 1 to 4 if you want to as well. We'll just give them a little bit and then go ahead and go to town. If you use carbocaine and it doesn't have epinephrine, just be aware that you may have some additional bleeding that can occur. Post-acceleration, this is pretty much what you'll see, these little dimples, but I want to walk through kind of some real cases with this, so we'll look at those in just a second. What do we do for the post-treatment soreness that occurs? Well, the important thing here is to know that you cannot use a non-steroidal anti-inflammatory. So Advil would not be recommended, Aleve would not be recommended, any of the ibuprofens. And the reason is that those are, exactly as they sound, anti-inflammatory. They actually reduce inflammation. So when we're doing any type of MOP procedure, any type of Propel, we're going to go ahead and have them follow up any discomfort with Tylenol. The reason, again, for Tylenol is it's an antipyretic, but it's not an anti-inflammatory, so it's not going to reduce inflammation. It'll just take away the pain. Just to back up and briefly take a peek at the different ways that we can perform accelerated ortho when we're doing corticotomy. We've got the kind of invasive one, the Wilco technique. It's, again, it requires flapping, and generally if you're going to be doing perio and there's other more invasive perio procedures involved, it's not a bad way to go. More conservatively, you can use the Pizio, and again, we talked about this is a lot less invasive. You don't have to flap tissue, but by far, the far right here, the Propel is minimally or micro-invasive. Patients don't need a big recovery time, very low cost, and the training is real easy. You watch a lecture and you can see how to do it, which is what we're doing. So the benefits to the patient, aside from being less invasive, is that you can use it with any of the different techniques. You can be very specific about where you want to go, as opposed to some of those other ones that we looked at early on, which are general. They treat the general entire oral cavity. we get much better predictability with it, and saves us a lot of time and cost for both the patient and the doctor. It also, by the way, is not reliant on compliance. And that's one of the challenges with some of those devices that the patient can have, is the vibrator or the light devices. If they're not using it, it's not working. So with that, let's go ahead and take a look at some cases. Part of the thing that you saw on that last slide was the reduced patient burnout, and this is where long cases really benefit from what we do with the Propel. Here's Leo. Leo we extracted bicuspidon. It's a super deep bite, so we're going to try and get him set up here, and I'm going to walk through just the steps of doing just infiltration in this case. And what we're going to do is numb him up a little with just some gel. We're going to go ahead and give him a little infiltration across the board, and then we're going to go ahead, after we've done the chlorhexidine rinse, we'll go ahead and start the Propel procedure. And that's what it looks like in action with the original device. You'll see a little dot of blood. That's normal. Again, we're going to look to go in between the roots, obviously, and create those little spots of inflammation. We'll dab it. My assistants will keep a little wet gauze handy. And again, that's a pretty realistic one. I'm going to come back and show you that lateral again, the lateral and central there in just a moment. That's what it looks like after you've wiped the blood. You just see those little teeny dots and you're ready to go. You can see I performed that all the way back near the molars so we could help settle his curve of spee issues. Again, just got the surgical tip handy. We wipe it off. You've seen that slide in action, and I want you to pay particular attention. Look at my cursor here. This is where I was doing one up near the papilla, and I slipped a little bit, and you can see I tore his tissue a little. Healed just fine. It was non-consequential to our treatment, but I kind of want to share all my mistakes and things with you. And just before I do this nowadays, I make sure I've got kind of firm placement when I'm using the handheld devices. There's Leo again after we've done just some little perfs, and this is how he looked immediately afterwards. We wiped it once with the wet gauze, went ahead and took our photos there so you can see a little bit of oozing. That stops within usually 5 minutes. We'll just keep some moist gauze on there, and then we'll have pop the aligners back in, and they're set to go. This typical results with cases like this, we were able to release those maybe challenging movements or speed up movements so that you level out the arches. So with that, let's look at some cases. This is Emily. Her chief concern was that she wanted to fix her crooked teeth. She's got a big class 2 going on, and she didn't want to correct her bite at all. She's getting pregnant and wanted to kind of get through treatment as quick as possible. Here's just a front view of Emily. There's her panorex. You see those impacted molars on the bottom. And you can see also, interestingly, the abfraction areas from her crazy bite that she had. If we look at Emily's landscape, which we see here is the start of treatment. Here's Emily's clean check. And I believe it was, I think about 22 aligners. I'm going to take off the overcorrection aligners, which I don't typically use, so I'm going to erase those in a second here. She has 22 aligners, and just to show you how deep that bite was, and also how kind of in and out the teeth were, you can see that one of the things we shared with Emily is that when we straightened out her bite and took care of her class 2, she'd have more of an open bite. She's got this class 2 div 2 type thing going on right now where there's some anterior coupling. So we go ahead and leave that bite in the back, and we're going to use the Propel just up in the front to help release those teeth and get some nice movement. We'll show this occlusal view for you, get a much better idea of where we started and where we want to go to. Here we are moving the teeth out, lining everything up. Same with the bottom arch. See, there's a lot less going on here. This was easier. We slowed down the movements so that they'd be even in both arches. That was what we were looking for. And here's Emily at the start. What we do with Emily, backing up here for a second, with all of our Propel cases, everyone's a little bit different. Again, I'm going to follow Burstone on this, so I want to have that initial phase of movement and the lag phase in full force before I start to propel. So I usually do that after the first 3 aligners, which we do at a regular 2-week, and then we'll go to the propel on a weekly change after that. So at week 6, she came back in. She's used to using the aligners now. She's compliant with them. She's comfortable with them. And she loves the idea when we say we're going to be able to go from one change every 2 weeks to a change weekly. Again, here she is. Again, this is at that point where we're going to go ahead and initiate the propel. We got through the first aligner. She had her baby, and we took a little bit of time off. She actually was pregnant when we did the propel. She wasn't sure at the time. We talked about it and went through everything. I probably would hold off on doing it when they're pregnant in the future. She was all good with it. We went ahead, and here's how she finished up. This is a T-scan of her bite. So we have things pretty much leveled out. You're going to see the T-scan. This is a really great device. If you haven't had a chance to ever get one, I'd highly encourage you. So right here, she's biting down. It's going to show forces and where premature contacts are, how much force is on each one of those. We'll go ahead and do any minor adjustments. In this case, we did it with dimpling. And then we went ahead and did an equilibration. And here was Emily after we were all done. Ended up with a nice result. I'd probably follow up with a little gingivectomy, get the soft tissue heights a little bit better. She was thrilled with where she finished out. Here's her final T-scan. The first few spots you see when you use a T-scan are just initial touches. They don't really count, as I like to say. It's when we first get right about here that when you see the flag appear, that you know that you're starting to come into contact. You can see she's got a very balanced bite at this point. We're thrilled with the result. That flag stays right in the middle there. That's about as good as you can get. It's really perfect for her and her bite. With that, we know that she'll be stable when she's all done. She's been done for, I guess, about a year now. Beautiful result. Lisa had a little bit of a different issue. She wanted to fix her smile. She's got some crowding and displaced canine, and she was ready to move out west. So the thing for her was that she wanted to get this done quicker because she wasn't sure she was going to be around. So see, she's got some crowding on the bottom. A little bit of crowding up top. Not a bad smile, but in particular, she didn't like the lateral that was sticking out there and was wondering if she could get that guy in. So here's her clin check. And you can see with Lisa, she had 16 aligners. We'll take the overcorrection off. 16 aligners again, so this would normally be about 8 to 9 months of treatment. When we're able to use the Propel, we can cut that time in half for her, so we're able to get through that, and a little, in her case, a little refinement that we did. So we got her there. Very happy with things. We went ahead and did a little bite analysis. I wanted to tweak the teeth in. Generally, when I do refinements, it's not because the patient's interested in it as much as I am. I know if I get things settled with a really great bite, their teeth are going to stay that way. Here's her refinement. I think it was 8 aligners. Yeah, 8 aligners long. So this was just about 2 months for us to tweak in the last little bit there. She was hitting on the anterior. I wanted to free that up a little bit so that she'd have nice anterior coupling, but she wouldn't be pounding on those front teeth, which is sometimes a challenge with clear aligner therapy. Here's how she finished up. So we got her bite nice and balanced and even. We went ahead and did a T-scan when we were done. Here's the T-scan looking at it from a different view. You can see exactly how the teeth are hitting as she's closing down. She had that one spot still up on number 9 that we ended up doing a teeny adjustment on to get things just right, but her bite was beautiful and stable, and couldn't ask for anything better than that. And then Jess is a nice, interesting case. In her case, we did a little equilibration beforehand because I knew if I just did a teeny bit, I could get her to close down a lot more on her teeth. She had a big CRCO shift, a big shift in her bite when she would first close down. just a teeny bit of adjustment allowed her to close down better, and then we could move the teeth a lot better. You can see we're correcting a cross bite here. She's got chips and wear on these teeth. They're kind of all over the place. There she is afterwards. You can see she's closed down a lot better. It's less than a ½ millimeter of reduction to be able to get that. If you've had a chance to take courses on equilibration, you can see how you're able to accomplish teeny amounts of enamel change to get big amounts of bite change. Now you can see not only that cross bite, but the cross bite back here. The teeth weren't still meeting the way that we wanted to. We went through treatment with her, got her to here. She also, believe it or not, was moving out to San Francisco and getting married. So we went ahead and kind of moved her through treatment, and this is where we got her finished up. She was, again, thrilled with it. It took us about 7 weeks of refinement. Went ahead and replaced the composites, got those looking a lot better. Ended up with a real nice result. And Jess is just, even from San Francisco, she routinely sends really great reviews for us and keeps in touch with our office. She's been just a great missionary for our practice. So just some questions now typically come up, and probably the biggest one is, how do you introduce this to a patient? Well, you want them to know what's going on. So, we tell them that we're gonna have to basically place some small little perforations in your bone. That the discomfort is minimal. We really like to think of it as a dimpling procedure, and that the big trade-off is that you're able to finish the treatment time a lot shorter than you normally would. We explain what exactly Propel is and how it works, and I like to use the fence post analogy about how we turn that concrete into quicksand so that we're able to move the teeth quicker through this softer bone that will reharden and get back to full strength when we're all done. I mentioned earlier about the dinging PDL, which I've had a chance to do twice. There's great literature out there, not from, believe it or not from the micro-osteoperforation for ortho techniques, but from placing TADs. There's a lot of great information from placing TADs, and how even if you ding a PDL, there's really no side effect afterwards. You just back out and you're all set. But what we'll use to avoid doing that now is what we call the floss between the teeth technique. It's real simple. Just take the floss, run it through the teeth, and come straight up. And you can look and see where you want to place those perforations. We will correlate that with our full mouth series and our Panorex as well. How do we manage the discomfort? Again, I said you can't have any NSAIDs on board as a pain control mechanism because it will reduce the inflammation. So we're really limited to acetaminophen or paracetamol to help reduce it. And if I feel necessary, the need, we'll go ahead and give them a couple Percocet. Typically, when they have the discomfort, it lasts for a day. They're sore for a day, and we tell them that, you're going to be sore for a day, but you're going to be able to go into work tomorrow. It's going to be a little tender there. Usually, it's the same equivalent as, I like to say, poking yourself with a toothbrush, although you do it in a few different areas. With that, what's the likelihood of post-operative infection that we see with this? And we haven't seen any, and haven't seen any in the literature either. Mostly because this is a very minimally invasive technique with Propel. So we don't use any antibiotics or anything other than the chlorhexidine rinse, the antimicrobial rinse prior to treatment. Changing aligners now goes from, in essence, once every 2 weeks to weekly. And we'll re-Propel, where I used to say we do it every 8 to 12 weeks. We're generally looking at 3 to 4 months. So we're looking at 12 to 16 weeks when we do Propel nowadays. I don't do it at all at 8 weeks anymore. There's no need to. What are contraindications for it? Well, things that we want to look for, and this is my own list that I put together, but bleeding orders would be one. I want to be careful of anyone who's had bisphosphonate use in the past. Again, these are just precautions. People with high anxiety are generally a great candidate for it. People are taking anti-inflammatories. Maybe they've got arthritis, so you need to check with that. They would be a good candidate. And anyone who might have had any previous radiotherapy or any necrosis of the jaw obviously would not be a good candidate. Lastly, how do I charge for it? There's lots of different ways you can do this. Some people will charge a regular fee for ortho treatment, and they'll add it in as just part of the value. Some people will charge for the device itself, and then lastly, you can offer a reduced time option. You can say, hey, instead of your case being a year, we'll be able to get it done in 6 months. and there's an extra fee associated with that. Sharing that and best practices, I want to just kind of tell you what I've seen from speaking with a number of practitioners and faculty members, and that is that we use it as just a build-in and to add value to the procedure. The reason in particular that we do that is that if I could cut my time from 12 months to 6 months, I'm saving so much extra chair time that it more than pays for the device itself. With that, I'd like to just share 3 cases. I thought this would be kind of a fun way to do this. I'm going to be doing 3 lectures with this series. First one today. The next one will be in December, and then we'll have a follow-up in January. We'll do a wrap-up. The December and January ones, we're really going to look at best practices, and we're going to talk more about anesthesia. But I wanted to get 3 cases that I could show you that we're going to start with and we're going to use Propel on, and then show you where we're at when we're done. So Sharon, the first person that we're going to talk about, 60-year-old female. She's in good health, and this is where I got the term snaggletooth. She said that she had a snaggletooth that she wanted straightened. Interestingly, she's got a class 2 occlusion, and I'm not going to change the bite for her because she's got 2 3-unit bridges down on the bottom. So we're going to leave the bite the same. She lives in Florida and comes up to D.C. Probably 4, 5, 6 times a year. So we're going to be able to treat her from D.C. and get her in good shape. Things don't look bad. You can see the bridges down here on the bottom. You can see she's got that class 2 Div 1 appearance, a little bit of Div 2 there, not really. Let's go ahead and take a peek at her clin check. And here we are. We've got first set of aligners is 12 for her. We're going to be doing a lot of reduction. I'm going to show you something interesting. I loaded the IPR right behind the canines, and it's kind of an interesting thing that we'll talk about, just an Invisalign thing. You can see right here, these bridges I can't move, but I need to resolve the crowding. I don't want to get in there and do a lot of work on those front teeth, and I don't even have access to do it in most of those spots. What I do have is a ton of extra porcelain here. So what we're going to do is IPR without actually touching tooth structure. We're going to take it off the bridges in this case. Now, for those of you that aren't completely familiar with how Invisalign moves, when they do IPR, they do not actually, on the clin check, shave down the teeth. What they do is just overlap them. So you're going to see the canines move back, in essence, into what looks like they're moving into the porcelain of the bridge. And I'm not going to touch those canines. I'm going to be able to do that IPR on those bridges and still have a good contour. It won't be straight up and down. We should get a nice straight smile from it. Backing up here, look at the maxilla. You can see there's pretty easy. My Propel is going to be all limited to anterior. We'll be able to get one, send her on the road, get her back. Go ahead and put on the superimposition tool, give you an idea of the movement that we're expecting. You can see it's mostly anterior, but I am moving the bicuspids up on the top to help idealize the bite. Now when we look at the bottom arch, just real quickly, once again, a lot more work we got to do on the bottom. Can't move these bridges, so those guys remain blue. All the movement's going to be on the anterior teeth themselves. And that's the result we're looking for. So we'll visit Sharon again in 7 months, see how she's doing. And see how she's doing. We take a look at a second case. This is Mary, 58-year-old female. I fixed her mother-in-law's teeth, and that drove her to come into the office to take care of her case. She's a really great case. She's got crowded arches, crowding, a lot kind of going on here. But if you look, this is a great case for expansion. So we're going to do this without doing any IPR. We are going to use the Propel technique to speed us through treatment. Mary's really excited about being able to do this. We actually did Propel on her mother-in-law, and she said if her mother-in-law could survive it, she could too, which her mother-in-law did a great job with. So with Mary's case, we're looking at 19 aligners on the bottom and 15 on the top. We've got 4 passive aligners there. And no IPR, we're just going to do expansion here, move the teeth in place. When I get to refinement, I may do a teeny little bit of IPR here to close these black triangles, but I always wait and see if I'm even going to have them when I'm done. We'll be doing some bonding to fix these teeth that have been worn. I think one of the cool things about Invisalign is to be able to look at something like this and predict where you want to be able to do your bonding, because you can do that and an orthodontist can't. So we're going to straighten out those teeth, and then we'll go ahead and level out the incisal edges, but you can see we've got a beautiful soft tissue architecture here and profile. Should end up with a great result. Lastly, George, I got a great case here for us to get started. I'm really excited to be able to show you where we get in December with him. He's got a big crossbite. I wrote left side. It's actually both sides. The left side's minor, almost edge to edge over here. The right side is the severe side. And we're going to be doing a single tooth extraction in the anterior to help accomplish our goals with him. So we will do the extraction and do the micro-perforation at the same time. That extraction area obviously is going to create enough inflammation right there that we should end up with more than enough to help accomplish our goal. And we've got 25 aligners on the bottom, 16 on the top. This is our planned movement. See, we have to have a lot of attachments. I take the attachments off when I get to the passive stage on the upper, and that's where we're looking to go. I know I'll have at least one refinement to end up with a beautiful result and get the bite that we want, but the Propel technique is going to help to really speed us along. So that's where we're at. Just a little peek at something that's coming soon. I can't talk a whole lot about it, but one of the nice things I like working with Propel about is that they're an innovative company. They're always coming out with some really great new techniques and procedures and devices themselves. This device will be available very soon, and I think it's going to help to shake up the market a little bit. With that, I'm going to open up the floor to questions. Some of the questions that were asked, Fayez asked, do I use a CBCT or any other imaging to determine the depth of penetration? And I don't use a CBCT for that. I can pretty much tell. It's a lot like things in dentistry. Once you start using it, you'll be able to get an idea exactly where it is. But I also oftentimes have the CBCT available, and in those cases I definitely will use it. My good friend Joe Besh is on the line, and Joe asks, what about my post-op protocol? Aside from, if I do a lot of Propel, we give them the Percocet, tell them to use the acetaminophen. We always follow up. I follow up that night. Usually they're not too bad that night. The next morning, they're a little sore, and when we follow up at the end of the day, the next day, they're in good shape. Just some other questions that we had that came in. Joe also asked, what about the velocity of a non-propelled tooth and the ability to quicken the aligner? Well, that's going to be the conundrum with this, is that you have teeth that aren't moving as fast. You may have trouble. So if you just look at your ClinCheck, you can do one of two things. You can put your grid on it and look at the tooth movement. But what I typically do, which is a lot easier, is just go ahead with the superimposition tool. And obviously those teeth that were blue on that one ClinCheck, I don't need to go anywhere near those with my micro-osteoperforation techniques. How do I assess the class 2 patient's TMJ stability? Great question, Joe. We'll go ahead and do that beforehand. Oftentimes with splint therapy, I want to find out where they're at as far as the joint is and healthy. It's a whole other lecture that we could talk about, and Joe, you and I could talk for hours about it if we want to. Big thing is I want to have a healthy joint. I want muscles that are comfortable, and in particular, I want a stable bite when I'm done to see that we're able to keep the patient in good shape. Can I show the slide for the pharmacies again? I'll be happy to. I'll do that in just a second. Anissa asks, do I have patients change out the trays 7 days as a standard? I haven't changed out with 7 days as a standard when I'm using an acceleratory technique. If not, you'll notice that the Invisalign aligners, the new material, new being 2013, it has a really fantastic, cool thing built into it, and that's it's got great residual memory. The aligner material will actually maintain its rigidity for about 12 days. So trying to cheat on it when you haven't done some sort of acceleratory technique typically will start to go off track about the 5th or 6th aligner. So we typically don't dip down below the 12-day limit when we're using regular techniques. How long does the patient stay off the NSAIDs for? we'll ask them to stay off the NSAIDs for the entire that 2 to 3 month period, and just say, stick with Tylenol. Again, that can rule out some people that might be interested. My athletes are people that actually are the most game for doing the Propel. But if they're doing an Ironman or something and they're going to be taking some ibuprofen afterwards, I say, you're not helping the teeth. You may help your muscles after your race, but you got to use Tylenol otherwise. How often? Martha asks, how often do I use the Propel device? I'm reinitiating Propel generally at the 3 to 4 month period, but I got to tell you, almost I'd say 80 to 90% of my cases, I just end up needing to do it once. The one kind of exception is I sometimes will, if it's a real complicated case, we're going to plan on doing it twice. Generally, that's more than 25 or 30 aligners. But I will also follow up with specific areas. Canines in particular, big rotations on bicuspids. Those are great spots where we may go ahead and go back with a second follow-up. I've had people ask for 2 slides, so I'm going to show both of those. One is the contraindication slide, and the other is the pharmacy slide. Here's a contraindication slide. I'll leave that up for a moment. You can take a screenshot of it if you like. And by the way, this is my own personal list. There may be others that you may consider, but I think the big thing is just to have a patient that can do it without taking the anti-inflammatories. We actually had one patient that had been on bisphosphonates, and not just the regular bisphosphonates, but had been on one for some cancer treatment earlier on that she had forgotten about. It was about 20 years previous, and we didn't have any side effects or anything to worry about with her. Here's the pharmacy slide. I'll leave that up for a second for you, and I'll see if there's any other questions. Again, thank you very much. I'll answer these other. I've got a couple other great questions here. One is Propel for facial and lingual, or just facial? And the answer is lingual too. We've used it a couple times now to try and drag down canines. One was on a teen, one was on an adult, as you would expect. The teen one was great. Patient did well as a lacrosse player. The adult, that was ankylosed probably to begin with, but we said we'd give it a try. So we go ahead and do the palatal. This is where that second generation one in my hand works great, because I can get really good placement and I can get it in there. We haven't tried it with the newest one, which would have a much better angle on it. I think that's going to be pretty much it. Once again, I want to thank you all for spending an hour with me. If you get to Washington, D.C., please feel free to stop by my office, stop in, and I'll take you out for some good sushi across the street.